So this is the old textbook, so it might not be chapter 36. So let's review the heart. The heart has 4 chambers. We have the right atria, right ventricle, left atria, left ventricle. Right and left sides of the heart. So you have the oxygen-rich blood. It enters the right side of the heart, and then it leaves and goes to the lungs, where it becomes, oh, excuse me, I got it backwards. I'm sorry. Oxygen-rich blood enters the heart from the lungs. Oxygen-poor blood enters from the body and goes to the lungs. Red versus blue in many diagrams. So superior vena cava, inferior vena cava comes into the right atrium, goes through the right tricuspid valve to the right ventricle, goes to the pulmonary valve because it's going to the pulmonary system. Pulmonary artery. Now this is deoxygenated blood. It's the only artery with deoxygenated blood because blood leaving the heart is always in an artery. And it goes to the lungs and it picks up oxygen, drops off CO2. Then it comes back to the pulmonary veins because the blood's coming to the heart. So it's veins. Left atrium, mitral or bicuspid valve, left ventricle, and then it goes to the aortic valve because it's going to the aorta back out to the body. To the lungs and back. So this is just the same, the blood flow. Pulmonary circulation. So layers of the heart. So inside you have the endocardium, just like endometrium in the uterus. This inside layer is the endo inside. Then you have the myocardium. That's the muscle. That's where all the action happens. And then you have the visceral or pericardium, epicardium. You have the pericardial cavity. And you have the parietal pericardium. So this is where all that fluid could build up when people have fluid around their heart. Endocardium, inner layer, myocardium, the middle muscle layer, thickest, does all the work. MI, myocardial infarction, that's this muscle tissue is dead, cannot come back. And this is where the troponin enzymes are released. This is a protective layer. Which of the 4 chambers of the is most muscular because it's the biggest workload and pumps blood the farthest? It's really important to know this. It's the left ventricle. So when people have heart failure, they can develop left ventricular hypertrophy. That left muscle of the left ventricle becomes really thick. So this, you can see it's already thicker because it pumps more, but in people with left ventricular hypertrophy, this gets really thick, and you can see that on an EKG. So you have the aortic semilunar. So you think lunar, think moon. So the moon is up in the sky. So the semilunar valves are up higher. And then the tricuspid and bicuspid valves. So bicuspid or mitral, tricuspid on the right. And then you have the aortic semilunar, pulmonic or pulmonary semilunar. Remember, lunar is up high, like the moon. Try before you buy. So you go in, the blood goes into the tricuspid, to the lungs, before it goes to the bicuspid. So try before you buy. Lunars are like the moon up high. Keep blood flowing in one direction. That's what it's supposed to do. Prevents backflow. So there's 2 atrioventricular or AV valves and 2 semilunar valves. So AV valves are atrioventricular. That's the valve connecting the atrium to the ventricles. Tricuspid on the right, bicuspid or mitral on the left. Pulmonic or pulmonary and aortic. Right atria to right ventricle. Right tricuspid. Try before you buy. Bicuspid, aka mitral, left atria to left ventricle. BM, bicuspid mitral. Sorry. Pulmonary lead up and out of the heart. Named after the vessels they lead to. Lunar means moon. Look up to see the moon. A mitral valve problem may affect which side of the heart? So the mitral valve is going to affect the side of the heart it's on, right? Because it's right there. It's affecting in between those 2 spaces, left side. Tricuspid right, bicuspid mitral left. Aortic. It's going to the aorta to leave the body. What makes valves close? Pressure. It is the closing of these valves that gives the lub-dub, lub-dub, lub-dub sound. The AV valves, bicuspid, tricuspid, close when the ventricles contract. So that's the lub. And that's the S1. So when these close, look, the semilunar valves, the ones that are up higher, that's the dub. That's S2. So you have lub-dub, lub-dub, lub-dub. So if you document S1, S2, that means that you heard S1, S2, and no other heart sounds. Now remember, S3, 3 looks like a heart failure when you hear S3. S1, S2, lub-dub, lub-dub, lub-dub. There may be an S3 or an S4 sound. These are irregular. These are not normal. All blood flowing through the chambers don't actually feed the heart muscle, myocardium itself. So they're coronary arteries. So the heart has its own muscle and cells that it needs to provide oxygen to. So these are coronary arteries. So if you hear about somebody having coronary artery disease, they're talking about these. So this is the LAD right here. This is the widowmaker. This is the one that's really bad if you get a clot in there. That's a bad heart attack type. So you have the LCA, the RCA, and the posterior. So see, this one goes back around. So those are the main arteries. They branch off the aorta, where they are again. It's that LAD, that widowmaker. Conduction system. A group of specialized cardiac muscle cells in the heart that send electrical signals causing contractions. So you have the SA node up here in the top. That starts it all. SA node starts it all. This is where it starts. Comes from the brain, but this is where it starts in the heart. And then it goes to the AV node. So the AV node is atrial ventricular line. So that's the AV node, the atrial ventricular node. And then it goes down the right and left bundles. So when somebody has a left bundle branch block or a right bundle branch block on EKG, this is the problem. And then it goes down, and then it goes to the Purkinje fibers, and then the Purkinje fibers send the signal to the rest of the heart. So if things are not going in this right order, that is chaos. So the aorta should contract first and then the ventricles, right? Because that's the order of things. So sometimes you might have pre-ventricular contractions. So that means that this part is contracting before it's supposed to. So it's contracting out of order. So SA no, starts it all. AV node, atrial ventricular node, right at the line. Bundle of His, left-right branches, and then the Purkinje fibers. Starts it all, AV node, bundle of His, left and right branch, Purkinje fibers. Sinoatrial node starts it all. It's the pacemaker of the heart. It's in the right atrium. Sends out regular impulses. Impulse is picked up and conducted by the AV node. That is sinus rhythm. If you see a document in a cardiac assessment that says NSR, that is normal sinus rhythm. Hey, the AV node. Atrioventricular node. Right there between the two chamber. The bottom of the RA receives impulses from the SA, delays the impulse before passing through the ventricles. So the timing of the SA node to the AV node is faster than the timing leaving the AV node. Very important. Allows atriums and ventricles to not contract at the same time. Otherwise, they wouldn't be doing anything. So the ventricles need to contract or squeeze the blood out while the atrium is opening, and then opposite, vice versa. So blood in, blood out, blood in, blood out. Otherwise, it would be stasis. The blood would not be moving at all. So lub dub can be separate. Bundle of His. That's that septum. That's the divider between the ventricles. It splits into the left and right. Leads to the Purkinje fibers. And the walls of the ventricle. Terminal ends of the electrical impulse. Enables the heart to contract in a coordinated fashion. SA node starts it all. Down to the AV node. Delay. So top of right atrium, bottom of right atrium. Bundle of His. In the septum. Separate left and right, and then Purkinje fibers. Terminal ends. Cardiac output. Don't confuse with urinary output, but the BP is related to the PP. Cardiac output. This is the amount of blood pumped by the heart every minute. So, stroke volume is the volume of blood in the whole heart. And you times that by the heart rate, which is beats per minute. So every time it beats, that's one volume of blood. That is your cardiac output. It's about 4 to 8 liters a minute. Ejection fraction. How much blood pumped out of the heart per contraction? Normal is not 100%, 55 to 70%. So what does low ejection fraction mean? Or EF. Normal blood flow in the aorta. Low blood flow in the aorta. Little bit amount. So different flow here. Afterload. This is the amount of pressure the heart needs to pump out of the ventricles. Afterload is the amount of pressure needed to get the blood out of the ventricles and into the next place they're going, either the lungs or in the left ventricle back to the body. How hard the heart needs to work to do its job. When blood pressure is too high, it makes it even harder for the heart to pump blood out. This is increased afterload. So you can see afterload is out, preload is in. This is the old book. It may be different in your book. This is actually a totally different textbook. This is the book before the old book. The aging cardiovascular system, conduction cells less effective, so you could have dysrhythmias. Atherosclerosis, so you have narrowing of the vessels. They're hard. They're not going to expand as easily. So you're going to have clot formation, and you're going to have decreased blood flow to the heart and organs. Resting blood pressure increases. So this is pretty normal with age. You can only compensate elevating blood pressure for so long. Left ventricular workload increases, so they get that left-sided heart failure. They also can get left ventricular hypertrophy. It can lead to stroke because of elevated blood pressure, or which we call hypertension. Decreased heart rate can lead to fatigue. It's not hypotension, sorry, it's bradycardia. And vein valves are incompetent. So you can have venous stasis and ulcerations. So if the valves in the veins, and especially in the legs, are incompetent, then the blood pools. That stasis means that it's staying there, it's not moving. And then that can cause ulcerations and problems in the legs. And you'll see that discoloration and shiny skin, hair won't grow. It's definitely an abnormal skin assessment on the legs. So causes of death, the number one in the United States is heart disease. So diagnostic history and physical. H&P. What information would be pertinent for the following? Chief complaint, past medical history, medications, past surgical history, family history, social history, subjective or objective information. The patient looks tired. That's subjective. Are you tired? Are you tired, patient? Weight is 185. That's subjective. That's something that you can measure. Patient says their foot hurts a lot. Subjective. That's what the subject is saying. Urine output 1,500 mLs in the 24 hours. That's subjective. That's something you measured. Vital signs. So when you see a machine, you usually see something like this. See it? Blood pressure is 160/80. That's too high. So you see this map right here? This is mean arterial pressure. That's 106. You want that to be at least 60, 65. That means that you're having good tissue perfusion. You have the pulse or heart rate, oxygen saturation, and their temperature. At 98 degrees when you convert it. What can we learn from a basic set of vital signs? What is a normal blood pressure? So normal blood pressure is actually now 120 over 80. 140 over 90 is hypertension. So the new guidelines are normal blood pressure is less than 120 over 80. So you can have between 120 and 140, you can have pre-hypertension. It's not borderline. There's no borderline. It's pre-hypertension. And then you have different stages of hypertension. There's the map. Things to assess regarding cardiovascular system. Level of consciousness. Are they awake? What might alter level of consciousness? Low blood pressure, low glucose, dehydration, slow pulse, hypotensive, definitely they can faint. That's really easy to faint with that. So pulse terminology review, normal pulse rate, 60 to 100. Pulse deficit, that's the difference. Pulse quality, weak, thready, bradycardia, tachycardia, greater than 60, less than 60 or greater than 100. Weak and thready pulse, low volume, like with dehydration or low blood pressure. Bounding pulse, this is fluid volume overload. So less the radial beats than the apical beats. So if the apical beats are 100 and the radial beats are 80, then that's a pulse deficit of 20. We already know S1 and S2 are lub and dub, caused by closing of the heart valves. Lub is the mitral and bicuspid valves. Those are the AV. And the dub is the aortic and pulmonic semilunar valves closing. Murmur. Turbulent sound made as blood goes through the heart. This is that JVD, jugular vein distension. Let's see, it's pulsating out there. When blood is waiting to return to the heart, seen in congestive heart failure. So these patients, the heart's not pumping blood enough, so it starts to pool. It's really severe right there. So extremities, color, movement, sensation. Remember CMS. So this is molted skin. It looks like that marbling. And this is what newborns have when they have that cold stress. I'm going to check for numbness and pain. Assessment EKGs. It's a graph of the heart's electrical activity. We will look more closely at EKGs later in this chapter, arrhythmias. So P wave, QRS complex, ST segment, and T wave. And then there's the P to R interval, ambulatory EKGs, Holter monitor. So they could have this for a week or a month, 24 hours, just different variations. If they have a symptom, they press the button, and then it's noted on the record of, like what, so they look at the information that was going along with that event. Have a normal day, go about your business. No showers, only sponge baths, because you have all those monitors on. Implantable loop recorder. It's a tiny computerized device implanted under the skin. It's like an EKG, and it stays there for a couple years. So look how small that is. It's like a paper clip. Just implanted. Echocardiogram, echo. Non-invasive test, no x-rays, no needles. Sound waves, it's the ultrasound of the heart. Assesses valve function, direction of the blood flow, regurgitation, where that's when blood backs up because the heart valves are not closing all of the way. It looks for murmurs, infections in the heart, and it looks for clots. That happens a lot with atrial fibrillation. There's echocardiogram, TEE. This is more invasive, gives a better picture. NPO, sedation, stress test, determine the presence of coronary artery disease. Walk on a treadmill and you're monitored. Might be a treadmill test or EKG, exercise EKG. They also have chemical stress tests where people who are unable to walk on a treadmill for whatever reason, they have severe arthritis, they don't have legs, there is a chemical test that they can do. Stress test. Don't eat within 3 hours. No caffeine or tobacco for 24 hours. May need to hold cardiac meds that morning, but that depends on the medication. Cardiac catheterization. So it's the angiogram image. Gram means image or test display, like EKG is a gram. So this is a visual test. See where it's narrowed right here? It looks like the LAD, if I had to guess. Studies that use an injected dye and a special type of X-ray fluoroscopy. Fluoroscopy is like if you had a camera taking a picture of like a regular EKG film, and a fluoroscopy is like if you had a video camera that was doing the X-ray. So it's like it shows motion, constant motion. Circulation of vessels in legs, head, and most commonly the heart. So this is where the catheter is threaded up, usually through the femur. Dye goes in so they can see. Examine the arteries, measure pressure and blood flow. So they look at the blood flow and pressures on the right side versus the left side. And they can do angioplasties, which they repair the vessels or put in a stent. Pre-exam. They need consent. NPO, minimum of 8 hours. Allergy to iodine or shellfish, because they could be allergic to the dye, iodine dye. Dressing over the puncture site, hold pressure, lie flat for several hours, no more than 30 degrees elevated head of bed, and check for bleeding, assess pulses distal to the puncture site, drink lots of fluid, dilute out the dye. So this is something that they can put on to hold pressure on the dressing site. And then this is a device they can put on that holds pressure. Some drainage, plug the holes. It's a little seal device. Thing a nurse says to a patient post-cardiac death, please lay flat. You may start to bleed. I need to check the bandage and insertion site from the test. I need to check your pedal pulses. Have a drink of water. Do you need a bedpan or urinal? Because you're lying flat, you're not getting up. So angioplasty with stent placement. So they have this occlusion here. They put the wire in. They blow up the balloon. The balloon holds open the vessel, and then they release the stent that's around the balloon. Then they deflate the balloon and pull it out, and the stent remains. Cardiac enzymes and troponin. These are enzymes and proteins that are released by damaged heart muscle cells. So CK, CKMB, CPK, and troponin. If had a heart attack, levels become elevated. Performed over an extended time, every 6 hours, times 4. Blood draw. So this is myoglobin, CK, troponin. This is, 20, 40, 60 hours later. Lab test. CBC measures various blood conditions. This is some normal hemoglobin male and female. Hematocrit, male and female. Remember, hematocrit's always in percentage. White blood cell. We're looking for infection. Platelets. So you want to make sure that they have enough platelets to clot, or they don't have too much, so they're going to have clotting issues. RBCs carry oxygen. Hemoglobin carries oxygen. So if there's not enough hemoglobin, they could have low oxygen levels, loss of consciousness, pulse rate, respiratory rate could be affected. White blood cell increase could be infection. Or if they don't have enough white blood cells, they might not be able to fight infection. And then clotting, bleeding risk if they don't have enough platelets. Lipid studies, cholesterol should be under 200. HDL, happy. Glucose, the high density, that's a good one. Low density, lousy, bad cholesterol. Triglycerides, it's just fat, mostly from what you eat. H is happy. L is lousy. BNP, a hormone stimulator to a diuretic, produced in the ventricles of the heart when they are overstretched, like heart failure. Can measure the blood. It can measure in a blood test and diagnose heart failure. The diuretic effect on BNP being produced in the ventricles. So the easiest way for me to explain elevated BNP is, so when you have a bathtub and you have that little circle drain thing below the faucet, when the water's getting high, that little circle is kind of like the BNP, and it tells the heart, hey, we have way too much fluid in here. And then the heart tells the kidneys, and then the kidneys pee it out. So too much volume, BNP, elevated, and then the heart knows that it has too much volume and it needs to get the urine out. C-reactive protein. This is a protein that blood increases with inflammatory conditions, and this is any inflammatory condition. So it's not specific to anything. It can be a predictor of cardiac risk. There are actually CRP cardiac tests versus the regular CRP tests, but these are not specific to anything because it could be any inflammation going on in your body anywhere. All right. Look for the next videos to come.